Thank you. I don't have any disclosures that are relevant to this presentation. So of course, the last Damien's talk referred to refractive cataract surgery, where patients usually come in looking to have LASIK, no matter what age they are, but they find at a certain age that they have mild cataracts and are suboptimal candidates for LASIK, and therefore consider one of the premium lens technologies. Patients are willing to pay for this technology, but their expectations are correspondingly higher. I'd like to start with a case presentation. She was a 54-year-old woman, CEO, having difficulty with driving at night and seeing PowerPoint presentations in meetings. She had high myopia and moderate astigmatism. Mild nuclear sclerotic and posterior subcapsular cataracts were noted, and she had a very long history of rigid gas permeable contact lens wear because of her prescription. She knew she wanted cataract surgery with the crystal lens, and these were her preoperative topographies. And you can see here that she has some corneal warpage in the left eye, and she has a slightly irregular pattern of astigmatism. And these were her initial IOL calculations after staying out of her lens for 2 or 3 weeks. I explained to her that she had corneal warpage, and she was very compliant and stayed out of her lenses for 2 months. And you can see here the difference in the lens calculations. I would have been off by 2 diopters had I operated on the previous calculations. You can see here also her topographies show a mild skewing of the radial axes. She had crystal lens implanted in both eyes, and 8 years after surgery, she remains 20/20 at distance and 20/30 at near with good intermediate vision. And according to her, even as of this year, she still wears reading glasses only in very dim light or for very small print. So this case illustrates some of the challenges in performing premium lenses, any premium lenses, and also some of the satisfaction to both the patient and the physician. There are other lenses available on the market, predominantly the multifocal lenses, and Damien spoke with you about the lenses that are available in Europe as well. We do have newer multifocal lenses that address the problem of intermediate vision. But truly, that's one of the strengths of accommodating lenses, is that the intermediate vision is excellent. It is a better quality of vision at night, and reading vision does improve to a reasonable level, although it's clearly not as good as it is with the multifocal lenses. Glasses are still required for near vision in the majority of cases, and because of the hinge design and the variable effective lens position, the rate of enhancement after these lenses is higher. And again, there's a small chance of capsular contraction syndrome because of the flexibility of the lens with displacement of the lens within the capsular bag. So the initial development of this lens was in the 1980s. Dr. Cummings and others noted that patients who had plate haptic IOLs were able to see relatively well through their distance correction at near. And studies done showed that there was 0.7 millimeters or so of movement on plate haptic IOLs with pilocarpine and cycloplegia. And the original mechanism of accommodation with the crystal lens was thought to be translational with the ciliary body contraction causing increased vitreal pressure, moving the lens forward. However, it appears that the lens also has an arching mechanism, and the contraction of the capsule slightly distorts the optic and moves it, presumably anteriorly, changing the radius of the lens. And this is illustrated in these ray tracing findings showing that there is increased power in the center with accommodative effort. So there's increased spherical aberration and increased coma. It appears that there is, thus, if you want to define it as such, a pseudo-accommodative component. In one study out of Spain, the objective accommodative response, meaning translational movement, was less than 0.4 diopters by ray tracing aberrometry in all cases. And the depth of focus appeared to be increased secondary to increased changes in the astigmatism of the lens, as well as the higher order aberrations of the lens with accommodative demand. Interestingly, and this was shown in other studies, about 14% of the time, the lens actually moved posteriorly in the eye, creating a slight hyperopia, but nevertheless, the patient was able to see better. Again, partially possibly because of increased depth of focus. The capsular rexus size in the study, I need to point out, was about 6.5 millimeters, and this is probably a little bit large for best functioning of the lens. So there are 5 generations of crystal lens, and the one that we're using now is the crystal lens AO, which has an aspheric design on the anterior and posterior surfaces of the lens. the spherical aberration in this lens is 0, so that any movement of the lens will have uniform power and creates an improved quality of vision. The Trueline toric lens was FDA approved in 2013 and is available in 3 cylindric powers. The rotation in the FDA studies was less than or equal to 5% in virtually all of the patients. It comes in 2 lengths, depending on the power of the eye, and the optic is 5 millimeters. It's inserted through the crystal cert injector, which is comfortable and easy to put in through the eye. Now, the ideal candidate is similar to the patient that I first presented, somebody in their mid-50s or older with mild to moderate cataracts, preferably somebody who's used to wearing glasses already and has low astigmatism and an active personality who's well-informed and engaged in the process. A less ideal candidate would be somebody who is close to emmetropia or who reads without glasses and likes their vision reading without glasses, or who has a negative personality. And we all know who these people are because we've seen them in our practices, or also poor visual potential. Contraindications, I think Sarah talked about pseudoexfoliation. I would not put this lens in somebody with pseudoexfoliation. And because it is a silicone lens, it's probably best not to put it in those with more advanced diabetic retinopathy. And of course, anybody with a maculopathy or a serious surface problem won't benefit from the technology. I tell patients to expect 20/20 or better uncorrected distance vision, although our average is between 20/20 and 20/25 in our center. We average about 20/30 or better intermediate vision and J3 or better in near vision. I do expect them to use near vision glasses, and the vast majority of them after 6 to 12 months are very happy. I show them on the near card what 20/40 looks like so that they understand beforehand what they're going to see. As in my first patient, it is extremely important to look at the ocular surface and rule out corneal warpage or a problem with form fruus keratoconus. So we work up these patients as we would any refractive patient. We use an IOL master, and again, it's important to repeat it if there are any inconsistencies between the 2 eyes. We generally use SRKT or Holiday 2, and we do macular OCTs and endothelial cell counts in all patients to rule out pathology in the front or the back of the eye. I target plano in both eyes unless I want mini monovision, in which case I target about -0.5 in the non-dominant eye. So for surgery, the incision for the crystal cert needs to be about 2.85 millimeters, and the capsule rhexis size should be on the smaller side. 4.5 to 5.5 millimeters is recommended. If you have a large capsule rhexis, the lens will vault forward and will not be able to move translationally. It's very important to do a meticulous cortical cleanup and ensure the wound is watertight with a low threshold for sutures. Obviously, you should not put this lens in the sulcus. That happens occasionally. And I instill 1% atropine and cyclopentolate in every case. I personally, in all of these cases now, use the catalyst laser. I use a 4.8 millimeter capsule rhexis, which is not centered on the pupil, but rather on the equator of the bag. And I do aura technology or intraoperative wavefront aberrometry in all cases. I suture not only the wound, but the paracentesis to avoid any leakage afterward. And now I use a capsular tension ring in all patients. Afterwards, the patients are advised that the lens can move within the eye and fall forward, so to avoid inversions like in yoga or straining or heavy lifting for about a month. And when you see these patients, initially the lens should be placed posteriorly in the bag. On day 1, the pupil will be dilated. Patients need to know that they'll have some trouble with night driving, and they should be instructed to wear reading glasses to avoid accommodative effort. In the week 1 postoperative visit, the first eye is assessed to help with the second eye. They will begin reading rehabilitation exercises after the second eye, and it's important to point out with these patients, because it's a silicone lens, that they'll need an 8-week taper of prednisolone as opposed to a 4-week taper, and I also use cyclopentolate for the first week. It's important, again, to challenge their near vision, and studies show that this type of near vision training may be of benefit no matter which direction the lens moves. And we download this from the internet, and we have them, they are a succession of books with smaller and smaller print that help them. They're supposed to use it through their distance glasses if they don't have distance vision yet, and use them for about 15 to 20 minutes a day. Accommodation improves over time and remains viable over the course of time. So in terms of complications, it's important to remember not to put this lens in if there is any rupture of the posterior capsule or a large anterior rhexis or an anterior capsular tear. If there's an oval rhexis, try to cover the hinges. Place the lens so that the hinges are covered. Please put the lens in the bag. And if the object rolls forward, try to deepen the chamber, but do not hyperinflate the eye with BSS. There is an increased incidence of posterior capsular opacification in these patients. In my hands, it's about 80%. There's a very small incidence of night vision problems, and there can be the most serious problem, which is asymmetric anterior vaulting. And this is due to capsular contraction syndrome. My first patient here who had it actually had several capsulotomies, and I yagged him, as is the normal case for these cases of capsular contraction, and then manually pushed back the lens, and 8 years later, he's still 20/20 in each eye with J2. It's important to note that there's been an increased upsurge of cases of capsular contraction syndrome recently, and because of this, I'm placing a CTR in every case, and I have not had a case of this complication since. I will discuss enhancements in my next talk on Tuesday, but I will note that you do need to do a YAG prior to that. So in conclusion, the crystal lens provides excellent refractive surgical options to those with mild cataracts. It's excellent for distance and intermediate vision, and patient expectations must be appropriately managed prior to surgery. Thank you very much.